amount of work or whatever. But so the first thing we're going to do is sort of recap. Oh, wait a minute. Here's the other thing. So my goal for these videos is to, at some point, I know I keep blinking, sorry about that, to do real-time problem solving on clients that I've never seen before that come in with a specific issue. They've had an overhauling, or they may have had it from somebody else, or body work, and do maybe one a month or something, and they're live and you can attend, or recorded later and watch, but have a little, not a subscription, but pay to watch it or whatever, and potentially get credit for it. CEUs for those in the United States, I guess. But anyway, as things unfold here, we'll just, go with it. But let's go ahead and get rolling. So let's take a look at Thomas. Stand you up, man. And I want to say thanks to Thomas and Grayson and everybody for helping me out, and all the people that gave me feedback. But just face this, man. So last time, for anybody that was here, Tom, tell us what's better and what you're aware of going on in your body. This is my process. This is how I do it with people. I ask them what's better or what sometimes, and then I I ask them what's better so that it tunes them into focusing on things that are better about their structure, because sometimes people tend to caught up in what's wrong with it and not look at what's better. So I ask them that to bring their awareness to it. Let me slow down. Thomas.
My external rotation in my hips has been better, so my feet are more laying on their arches than they were before, and my hips aren't pinching when I stretch them like they used to. So I have a lot less stress in my hips and my knees than I used to before.
Yeah, and if we remember last time, he was having a lot of pain in his medial leg hip joint because he was working really hard to medially rotate his legs, trying to adapt to hockey, being a hockey goalie. And he was pulled down considerably more into this pattern. And, we still see some of this. That's okay. We'll get there. But what's better is he's not nearly as head forward. His eyes are on the same plane, relatively speaking, across here. And turn around for me. He's got some curve here. He's still pushing himself forward here to get up. But he's got a little more curve here. And he doesn't have as much of this pulling down and pulling up on this side, that rotation. So let's just walk him and take a look. And I'm going to kind of walk through my process a little bit more in a more refined way. So go ahead and walk down the back. So the first thing I do when somebody takes off is I just sort of relax, and I don't try to make a judgment call on anything. I just sort of take it in. And the first thing that sort of jumps out to me, you keep going, bro, is he's working easier, but in a different way in his structure, and he's still having a little trouble getting his legs and hips and pelvis and spine to work as a cohesive unit. And like right here, he has a little.
Come closer to see that.
Can't see it.
Come closer.
Yeah. So right there. So he's having trouble here. If you can see this pointer, but maybe not.
No, you can see it.
He's having trouble getting from translation through his pelvis from one leg to the other. Okay, turn around. And if you look at it, he says the same thing on this side. So and you can see he's doing this in his pelvis, like this is short, this is short, this is short right here from the crest to the tubes. And then he's short from the ribs to the crest here. This is short also. But so he doesn't, if I shift him side to side, he doesn't translate through his sacrum very well. He kind of, if I just feel of it, because this is just my process, I'm feeling, where does he do that? He does a lot of it up on the top. He pendulum throws himself back and forth. and his feet don't want to accept the distribution of weight. Now, if I slow him down, he'll do it a little better. He can come over here. See, he goes way far this way. See how all this tissue comes this way. And if I push him the other way, what he does is he starts to lean into this side bend that he has going here. And if I keep pushing him, then he rotates to make up for not being able to side bend on this side of his spine. Now, since we're going to try to focus on feet, let's take a look at his feet. And from the back, you're good, Thomas. He looks pretty good. You know, this stuff is not, you don't see any huge deviations of his calcaneus or anything like that. Turn around for me, sir. He's got a little bit of collapse here where all these metatarsals are rolled medial. These are rolled lateral. See how his whole foot goes that way? This is a real common pattern. And this ankle is rotated that way. It's rotated external. This one's coming medial. And in my world, that comes from this, like Jan's. Here's what I use when I'm processing. I think about a lot of things. There's Jan's internal-external model, which is a really good way to kind of assess things. But a lot of them fit into that. It's just a place to start. But also, you know, I started playing with this theory that over time I started noticing there was a real common, for lack of a better way to say it, universal pattern among structure. And what it is this left side bend, right rotation. And what that does is when somebody does that, it pushes this femur down and immediately rotates the whole thing. And then see, it dumps this arch, this left arch, and it lifts this right one. So that's where he's at. And this gets really short through here. This gets pulled on. And if I bring him back the other way, he can turn that way much better than he did last time, but it's not exactly the same. His spine doesn't want to go into a side bend. Actually, let's turn around and do it. His spine, if I side bend him here, left, there you go. See how he just bends. And so I call this kind of a mechanical, because this is mechanical movement, because he's already in that pattern. His primary pattern, this is short, his glutes are pulled, and this is all pushed forward, femurs pushed forward. And then he rotates, and this comes up, all these ribs come up and back, so they're going to be narrower here, they're going to be flatter and wider on this side. We bring him out of that, try to take him the other way. Immediately what I feel is he compresses on his hip joint, boom, to make up, because he doesn't side bend here as much, which he's starting to get some. And then his ribs compress. See, he doesn't get any real side bend in his lumbars. And if I pull him over and get him to turn, so I can get him to turn a little bit, but what he does is he can't recreate this movement going the other direction. And there's things on this side too that aren't going to be the same over here. So that's sort of where that's my basic model of seeing is internal, external, lines of transmission. And I say basic because if they've had any kind of impact injury, and I've heard multiple people say this, Jim Asher, Michael Salvesen, basically all the rules go out the window if there's impact involved. And almost all of us have had that, car wrecks and things. So with that, let's walk him and just look at his feet, see what we got going.
Do you want me to follow his feet?
Yeah, follow him a little bit. See, just go ahead and walk, Thomas. You're good. It's not too bad. He's actually doing a pretty good job of motoring along. He lands and then sort of collapses a little bit. And he's got some ankle popping issues. He tends to just turn his knees medial as he tries to put weight over there, which is part of his leg patterning. Okay, let's stop him here. So what's happening here is he's really externally rotating his femurs to turn your leg out. That's where he goes to what I call neutral. Now, it's a little past neutral. It's more right here, but no, you're good. But that is another, see, he's sort of in between two patterns, internal and external. And so we want him to be able to, I suspect this is an overlay from the other pattern, but we don't know that. So I just take it for what it is in the moment and not worry about it too much. Now, here we go. Let's turn you on. So he was talking earlier about how he feels tight through here now. And if we put him in that external pattern, go ahead and rotate those out. That's his home right there. And how can I tell? Because when I move his spine a little bit, I can rock his pelvis. He can go posterior, and I can do this. See that? He moves pretty good. Now put your feet straight. He just wants to, he can't do anything there. He just falls down. Actually, what he does is he brings the fronts of his feet up. So, but if I push him this way, bring his pelvis up, his pelvis doesn't want to move. All he does is rock back and forth on his ankle joints. And he pendulums like up here at his head. He doesn't move. So now externally rotate your legs. Now if I do that, he's got a support system where he can move his pelvis posterior and anterior. And some of this, I figured out over time, but take time to play around with things and figure out where they work and where they don't. Now turn your legs medial, like you were last time. Like turn your feet inside. Yeah. Now this is his hockey stuff. See, he does the same thing. He just shifts back and forth. He can't let his pelvis have a neutral and an anterior tilt and a posterior tilt. And this is his old hockey overlay. But what I feel is that he's so externally rotated. This is why he hurt in the front. All this tissue is just wrapped backwards. Okay. Now turn around and turn your knees in again. And this is this I think what we're seeing when he walks, this stuff from the hockey. So walk with your legs like that for me. And this is how I figure things out. I have him do things. It said that doesn't work. now go back to neutral. Yeah, just like that. Now turn him out and walk. Oddly enough, what happened is he got a lot more movement right here. This is what I could see. And it's not great, but it freed him up enough to have some stability and some support. So let's go figure out what's going on here with his feet. Let me look here. And in my world, I would, depending on what was going on here, I may come and do a little bit of work here, but we'll see what happens. Let's just lay you on your back. Slide you down a little bit, right there, perfect. So this is how I do what I do. I'll just feel things. I'm not using a lot of pressure. I just kind of feel, where's the tissue going, what feels, I don't want to say normal, but congruent and what doesn't. And in general, his legs feel fairly, congruent. And if I push back on his knees, just check his screw home, it works pretty good. Another way to do that is just pick this up. Just pick their foot up and you'll feel it turn. I do that a lot. Yeah, see that one worked. This one works pretty good. But what he does is he goes way external. And then you can see he just keeps going. And then there's that collapse in his arch right there. Right here on this one. And as it goes that way. So let's feel what happens. When I do it, same thing over here. It comes this way. And as it comes around, there's the collapse in this one. So that goes along with what we were seeing. When I try to turn him back, what I feel is he starts to use his back. So I'm taking the time to figure out what's going on. And then what happens is he gets short. He's short on the lateral side of his foot, and then he dumps his ankle to get around it. And, we know that we need a good lateral arch to have a good medial arch. And I'm not a huge proponent of just whacking feet to whack feet. I work on them if they need work. Because I've seen people get weird results or bad things happen to people just getting their feet pummeled. So, here's this shortness on that lateral line if I turn his foot. that lateral rotation. Very similar thing on this side. And what I feel it do is go up into his back. He starts to compensate higher up. Now if I roll his leg in, see how this pops up? His whole femur, it won't even stand. Hang on. He doesn't really have true rotation in his femur head because of all this quad tissue is wrapped. Where's my pen? Forgot about my pen. He's going this way. This tissue's short going this way. But at the same time, part of it is coming underneath that is coming back this way. So and it's right here. He's got an incongruence in this right here. Right there's the transition point of that, where this goes lateral and the compression from the side bend, and then he goes back this way. So it's right in here. It tells me, hey, he probably needs a little attention there, as well as right here where it transitions again. This one is more medial, but the tissue's being pulled up like this. So all this side's going this direction. And I feel a similar spot right here, but it's doing a different thing. It's going this way. And all this tissue here is being taken this direction. And then he does some stuff back, well, actually does it right here. He gets back around it down here in his leg. That's how he corrects it. It's funny. And on this side,
can you move him back?
Move back a little bit. He corrects it. Corrects it in the back of the leg back here. Right in here. He uses this to correct the lateral rotation. All right, so let's just go on here with the feet. So when I test his talar glide, it's okay. It's not bad, but a lot of times I'll see people just push up on the foot. That's not testing it. It doesn't glide. It compresses, but it doesn't glide back. His sort of glides, and then I feel it stop by this same stuff I was feeling earlier right here on the lateral side. It won't let so what he does is he drops medial because he can't glide backwards on the talus. Very similar thing on this side. So this is short and it's not allowing, it's causing this. All right. Now we know these bones, they're going this way. These are going this way. So we can still have shortness here and have this problem, and have the opposite problem on the other side, still be short on the outside. All right. Flip over real quick for me. It seems like it's taking a long time to me, but come on down there. There you go. And you can also test the glide by pushing on them. And if I just push his foot a little, you can see it just wants to do that. So that tells me most likely this is short. Out here you can see how this lengthens, but this doesn't. He doesn't have enough, he can't get any glide. I can bend his knee and get it to come back, but not if it's here. It's real tight. And the same thing on this one. You can push it and you can just see it go that direction. It just pulls right over there. So you don't have to spend a bunch of time being super sophisticated at starting out figuring things out. Now, certainly you got, flip back over. Implications with, if this is going that way, you can probably assume your cuboid and all these are going the same direction. A lot of times you'll see these two toes doing something weird. They'll be going this way and then they correct by turning one toe in or this toe in, but usually it's right here. And also you got your subtalar joint right there, right through there. It's important. So, we can get as sophisticated as we want with our analysis, but sometimes you just got to start. So with him, it's sort of interesting because there's things I want to do, but I'm not when I start to bring him around, I feel like I really need to get his medial arches more than anything. So I'm still thinking about it. I'm trying to figure it out. So I'm feeling, no, we need to get this right here. So when I hold it and I turn it, what I feel is this tissue on the top of that fibula and tibia won't let that come over. So we're just going to go ahead and get a little bit of that first. And what I'll do, since I want it to go that way, I'm going to put him in the pattern. And then I'm going to use my trusty elbow. When I get into something, I just ease, and then immediately it starts to let go. And I'm sort of cleaning my way through there. I know we got these compartment here, and there's some tendons in here that are not wanting to be nice and glide around. And now as this, my elbow's starting to free this, his foot's starting to come back toward me. I'm not moving it, it's just coming that way. I'm nudging it a little bit. You all right, Thomas? Yeah. Here we go. We're rolling now. What I feel is this anterior compartment starting to lift upwards. Because we know this is pulled down, right? This side, from that side bend, he's pulled down on this. So I feel that the superficial stuff start to come up. I start to feel the septums and things in here, trying to find a little bit of home for organization. Right here's the seam I'm working on. It's right there where all this is being pulled around. So he can't come up. So I have to get in here with my knuckle. And I'm pulling back on his foot, give it a little bit of tension. And I'm just hanging out. I'm not tremendous amount of pressure, but I'm thinking about the seam. There it goes. So I'm holding his tibia and I'm turning his ankle toward me slightly to give it a direction. And then I'm chipping at the edges of the tissue where they're glommed together. There they go. And yeah, here we go. And it's starting to move, and as it starts to move, it wants to go more medial. So I'm just going to let it go. And it's kicking me up here a little bit. And one of the things I'd like to say, too, is restrictions. You know, there's a huge array of restrictions in structure. They can feel real watery, membraney. They can feel like to beef jerky type feeling, dried out. And it's real important to start to feel those things, and you treat them in different ways. Like this feels ropey and overstretched versus tight and dehydrated. So I'm thinking about that, and I'm telling this to what I want it to do. I want it to go up. And there we go. There it goes. It's coming around. See right here, there. Now I'm not putting much pressure as far as the turn, but it's starting to untwist. There we go. So I'm barriering with one arm, giving it a little nudge with the other. And at the same time, I'm thinking three-dimensionally through. I'm Rolfing through into the deeper area of the leg, and I'm putting a little torque and talking to those deeper tissues and saying, hey, you can come with me. And there we go. Now I feel his knee starting to come with me. You all right, Thomas? Going to sleep. It's not uncommon for people to start passing out on you when you get into the good stuff. And, you know, I hear things are, here we go. Now all I'm doing is I'm pulling that layer. There it goes. So I'm going to draw on you again here in a second. Now we got this stuff going this way that's pulling downward. And right here, I got a layer where he's been working coming back this way. And when I say layer, I'm trying to stay away from naming muscles because I only think in terms of tissue when I'm working. I mean, there is a relative idea. We got the tibialis anterior. We got all these things in here that flex this stuff. But I'm looking more for the relationship of what's happening. Now, if I bring him over here and I push up on his foot, I can see this it's starting to go backwards because this tissue isn't holding him like that. So when he's, all right, let me get a little more of this. I'm gonna get on that. So I'm gonna We're gonna go, there we go. So I'm taking it in, and then I can also get him to help me and say, hey, Thomas, turn your leg lateral. Just easy, easy, just a little let off. Actually bend your knee up and down, just a little, that's it. There it goes, now it's coming with me. And I'm not trying to torture him, and I get a little piece of it, and then I follow it, and now there's a nice piece. It's really kind of glued down. And so all this tissue is being pulled toward his ankle. Now I'm in another little seam right here, a little divot, and where some layers are not wanting to play. There they go. There goes the whole leg. Now see, that all just got congruent with the rest of the leg. Much better. Now, if I come over here, now I can bend this, and it doesn't immediately just want to go there. It's got some movement in it. And when I say movement, yeah, there's some glide. Now it's really, I can take it back. It'll glide a little bit. But while ago when I brought it up, it just wanted to go there. Now when I do that, see, it can come up. All right. I feel like you, all right, man? Yeah. Now, see, on the other ones, when I bring it up, it just wants to go out. And I suspect what we're still dealing with here is they're pretty congruent. What they do is the overlay from that internal rotation of being a goalie. So that makes more sense to me. And see, that one will just bend now. See, that one still wants to do that. So this is where a good example of how somebody can have, this is common, have real crazy, oh, this hurts here. But it's really, this is more the issue, because what he's doing is he's going here, and then he's trying to externally rotate back again right here. Okay, let me come over this way. So let's talk to this one. So since it's essentially doing similar thing, I'm just going to treat it like that until we, wow. See, that one goes even further. Which hip was the worst one when you were hurt? Yeah, this one goes way further. Now, so if I take into consideration, he's turned this way in his pelvis, and this leg's going this direction. So he's got tissue pulled up, and then he does the crazy stuff to try to get around it. But he was doing it in the femurs, what he was doing. There's that compression in the head of his femur. That's how he turns this whole leg medial. If I push down here, that's how he drives that medial. This femur, tibia, ankle, and foot. So the question is, do I work here? Do I work here? So this is an assessment. So if we went from where we were earlier, that was the bigger pattern, where he compresses here, and that's how he was making up the difference to get his hockey stance. Well, let's just go ahead and get this, And I'm going to come in here, palpate a little bit. And here's another thing. Sometimes you actually have to put pressure on something to feel where you need to be. And I'll do this all the time. I'll put a little pressure on it. I'll pull it around, figure out where I want to be. I'll turn it. In his case, it's got to go further. Can I turn it further? It's got to go even further. There's where, that's what was doing to try to be hockey. And then I don't know how he was getting his foot. Oh, he's using his back, because when I do this, his pelvis makes some adjustment. Well, let's just get this. Let's see what happens. So I'm going to hold it. And I've got him turned in here, and I'm not really trying to do anything, but just put a little tension on it and see where it goes. Okay, now I'm starting to get information, and what I get is the fibula is being pushed forward, but at the same time, it's rotated in. So doesn't mean anything. I'm just getting information as I roll. Here we go. Now this is starting to come out of it, just like the other one was. We're going to take it over here. Keep that going. I'm just hanging out, not doing anything. What's happening? There it goes. Now, see, something's starting to happen, so I'm just going to let it happen. And what I feel is his foot's trying to do this. So it's like, oh, so what do I need to do? Foot's trying to do that. What I feel is it can't do this because the foot isn't can't come around here and push this femur where it needs to go. Now that I got that one spot, I got to come here. And what it feels like to me is the edge of the tibia is dropped down on top of the talus in that joint. Is it what has happened? I don't know, but it's what it feels like. And I don't really care other than that's what it feels like. And that is, I'm going to push that tibia, get in that joint space a little bit, push it up. There's the joint space. I'm on the end of it. I'm pulling a foot down to try to create a little space. And now his whole leg is starting to rotate lateral. Can you feel that, Thomas? Thomas passing out on us. Yeah. You know you're doing some good work, and it's deep, and you're not killing them when they start going into that zone where you're like, oh, yeah. Now, it's starting to change. I'm in the joint space there just a little bit. I'm not using a tremendous amount of pressure. But I'm being, pressure is relative. You use what you got to use. And, this is a sensitive area because there's nerves. It's close to the bones are close. And what I find is people end up using way too much pressure, and body workers use too much pressure instead of taking their time. And look at this, man. See, this is unfolding crazy like a little baby club foot. Did you use this for hockey stick, man? I'm just saying, jeez. But this is not uncommon. I see this a lot on people. And so I'm just playing with it here. I'm not trying to, his knee's not stressed. His hip's not stressed. He's not blowing any bubbles where he's falling asleep. Now, here we go. The tendons on the anterior part of the leg are starting to come around. And I'm just following the movement in here. And I haven't called for any movement yet because it just hasn't popped up that, hey, move this certain thing. Now, here we go. There's that leg going more medial. So that's how he was turning that leg back lateral after this crazy medial stuff. He was just cranking his foot around. That's how he was driving it. And here we go. And it probably looks like I'm pulling really hard on him, which I'm not. I'm just putting just enough tug that I tell it, I'm asking it to do something. And then I'm waiting for it to do it or do something else so that I can adapt to what this is doing. See, that's pulled way down. Or the foot's pulled what? There we go. And here's the tendons. The tendons are coming down here like this, but then they get dragged over here in this direction. And so now what I feel is I got to come get a little bit of the top of the arch there. You all right, man? This is what I say. I'm not a big fan of just whacking feet to whack feet. I have to have a reason to whack feet. And I'll give you why. Years and years ago, this guy came in and he had like these flat feet. And I'm like, I'm the man. I'm going to fix those flat feet. And he came because he hurt his rib playing golf, and he got pissed and slammed his golf club on the ground and got a rib out. So I got the rib back in, and then he was wanting to work on his feet. And I'm like, yeah. So here I go. I do all my, cuboid moves and navicular moves, and man. And then he calls me up, man, my foot's killing me. Because he already had pain for a little bit. I worked on it again, and then this voice in my head the third time around went, just put it back. So I literally put the bone back where it was in its collapsed state. And when I did, his problem went away. He was happy. So it was a lesson in some things just need time to change, or they don't need to change at all. Because he was not the type of guy that was going to, he was, he wasn't in it for change. He was just in it for let me feel good. So, you got to, sometimes have to figure out what your client wants. Some people aren't in it for the change. They're in it just to get rid of the pain. And that's a different client. Not that they can't change, but it's a different conversation. Here we go. Now, I'm taking it further. Now, see, as these bones start to come around, there we go. I'm just turning it. I'm pulling those metatarsals. And what I'm doing is I'm turning them right here. There's where they go this way, and they apex right into that fifth metatarsal and that calcaneus over here on the cuboid side. And I'm turning it. Now, barely turn your knee lateral for me. No, the other lateral. There you go. And there it goes. Now, see, I'm holding, there they go. There goes the foot. I'm getting these bones, and I'm focused around in between the third and fourth there because I know that goes into the subtalar, and I'm kind of pinning it against the table as well. Keep turning, brother. Yep. Let's bump it and let go. There it goes. There it goes. There goes the foot. There goes the foot. There goes this foot. And there it comes. There it comes. Now the whole thing's coming this way. Keep coming. There you go. Now what I feel is the tibia is staying here. It's not getting sucked down on top of that, and the fibula is starting to move backwards. There you go. You good? Keep going. You got it. You can do it. I got faith in you. There you go. You can have an ice cream sandwich after this. There it goes, right there. Now, what I feel as this shifted, it's still jammed up right on that cuboid just a little bit. So what I'm going to do is just put, there it goes immediately. I just pushed down on it because that was the direction it wouldn't go. There. There's his whole leg going that way. And now when I bend his foot, his knee comes up, which I like, and he stays relatively in the middle. I think we should walk Thomas if he can wake up. You all right, man? Yeah. I got to keep a track of time. I'm trying to keep it time-wise to the time so we got some time for questions. Trying to explain the demons in my head while I'm doing it's hard.
Sorry.
No, just let him walk.
Okay.
Just let him walk. And, you know, you can see him processing. You just walk. And he's trying to figure it out. His body's trying to figure out what's going on. And here we go. So I'm just sensing what's going on in the big picture here. And he's trying to figure it out. You know, now I can see how he uses his arms more as leverage to pull himself up. He uses these as, you know, to keep his body upright. Just walk, keep walking, just walk. Just do your thing. There you go. Now, he's still got some collapse. That's okay. I ain't worried about it too much. The right one looks stiff, and the left one's still collapsing some, that's fine. Everybody's got this stuff. What is your experience of that, Thomas?
My right knee's tighter than my left.
Right knee's tighter? Yeah. Okay. So he's giving us feedback. So tight in what way?
It feels pulled inwards both ways.
Inwards, like turn around and point. Yeah, okay. All right. So, all right, let's check that out. And you can see he's working hard there. All right, let's lie him back down. Feel what we got. So when I get into something like this, you know, we could have equally probably done some stuff on the back, but, you know, he has this pattern and all this tissue's pulled up, right? It's coming this way. You can see it right here. This is real common too, by the way. You'll see space on one side and very little space on the other side. This is the side that's pulled toward the knee. This is the side that's pulled away from the knee. And it's not uncommon to see this stuff piled up down here where it drifts down. So let's just get his knee going. You all right? There you go. He's holding on. You'll see this too. You'll see him still hold the pattern sometimes when they lay down. And whenever I feel that, what I feel is it's going like that. So all this is being pulled. You can see the line right here. Where'd my pen go? I lost it. I got another one. I had another one. I've lost both of them.
No, it's right here. Ooh. Here.
Right here. That. So you can, the quad's doing that. The rectus femoris, right? You're supposed to be here. It's over here. It's following this line, so it's going to drift with that. Here's his adductor. If I palpate it, it's right here. There's the edge of his adductor. So it's pulled way over here with all of this tissue. So, you know, there's an option for session 4, you know, when you're doing a 4, you're figuring this stuff. See, when I take his leg back that way, what he does is he dumps at the knee. And you can see this gets long, this stuff at the top on the surface. But this doesn't move. The femur doesn't actually rotate. And right here is where the quad and his rectus, there's a rectus right there. Rectus. But the deeper quad, where it attaches there on that medial, the vastus medialis, is that what it's called? Is just tight. And so that huge attachment site is pulling all of that tissue that direction. And he overrides it by dumping his knee. So let's take a little bit of that out of the equation. You good, man? Thomas may be in nap mode here in a little bit. Last time he got wired up because we worked on his head. And then, I mean, I could argue working on his head again instead of doing this, but, you know, he's got some things that are going on. So what I'm going to do is I'm going to palpate this, and I'm going to find where it's being pulled up. So one thing you can do is just push it up in there. That's the way it's going. See, it goes real easy, not so good. And what I feel is it comes to about right there is the edge of where all this is migrated to. There's a little septum. There's the quad. Seam, whatever you want to call it. So all this tissue is going this way. So I'm going to put my elbow in that seam. There's the edge where it's all glommed onto the bone. And I'm just going to bump it a little bit. I'm going to ease down in that. I'm using my elbow like a wedge. And I get on it, and then I just talk to it. And I say, hey, come with me. There you go. Immediately, it starts to let go. Now, you'll see this. See that? If y'all remember last time, he had this huge TFL was all piled up here. This is starting to let that down. But as you get on that, now I actually feel that's part of his adductor fascia right there. It's pulled way over here. What's attached into it. I don't want to say it's part of it. It's still quad. So you all right? So quads, you got to be nice on quads, man. You start whacking on quads, you know, people get stupid and hate you. So you ease into it because there can be, and I'm not using a lot of pressure. I'm just getting on the edge of that where it's stuck, and then I'm nudging it, asking it to give me some love. And there it goes. Now I start to feel this seam right here where the vastus medialis is pulled way that way with that attachment. And I'm nudging it the other direction. Now I'm going to have him turn it in a little and then turn it back out. And I'm going to bury her there. So I'm working against him in sometimes, but what I'm doing is I'm just not letting the femur turn, but I'm letting the tissue turn, which is sort of a paradox. But here we go. I'm just following that seam, and I'm come back and get a little nugget of it up here, a little bit more right here. And as I get it, what I feel is this part up here is starting to drop out of the hip. And essentially what I'm doing is I'm telling it. I'm not saying telling it in a bad way. I'm just asking it, hey, will you unwrap right here? And, you know, I'm giving his tissue some instructions, but at the same time, I'm following it, but not following it. Following is not really the correct term. I'm just being present with it. And as it starts shifting now, it's going to start to roll medial. And as it does, go ahead, take it more medial. There it is. See, I'm taking it into how he gets around it so that it pops this, it puts the restriction right up underneath me. I could have lied him on his side and done some stuff there, but, you know, whatever. 6 and 1/2 dozen of another, but you can just, and I'm just bumping it. There we go. There we go. There it goes right there. And, you know, like, a lot of times people say, oh, see, IT-band. Well, IT-band can get yanked. It gets yanked around with all this quad stuff. Now, when I roll him, when I take him that way, it still needs some more, but it's coming. We want to get a little bit of that. So in his case, I'm probably going to I'm just going to turn him into it, bring his leg over here where I can get it off the edge. And I'm going to go right into there where that femur won't go that way. And I'm just feeling with my knuckles. Feeling. Right there. The back, right here, is where all that IT band stuff comes sort of together, and the quad. And there's a little tight ligament right there, but it's part of this fascia off the leg right here on the side. So I'm just going to get in it. So I won't let that femur go. I'm going to turn it a little. Nudge it. There he goes. You all right, man? Yeah. There he goes. Now, it's starting to carry me back into the back side of this quad over here. So, interestingly enough, but also what I'm feeling show up is how this won't go. You can see this whole line right here. So what do? You okay? Your knee okay? Some people you can just work on like this. Other people you might have to prop them or something. But I'm going to get this line right here. So this is being pulled over like that. Actually, right there's the restriction right there. So I'm going to go into that seam. And some of this is the tibia, the pieces of the tibialis anterior, pulling this up. There it goes, right there. So muscles, you know, bits and pieces can do other than what their recognized standard muscle does. I find it all the time, like a little piece of, you know, maybe the tibialis anterior, these upper fibers are actually acting like crazy lateral tibia rotators or something. So don't be attached to a muscle does a certain thing, because some fibers within it can do other things. And I remember one time talking to Jan Sultan about it. I said, hey, Jan, you ever think people grow odd things on them that just the body grows it so it can do a movement? He said, Parrish laughed and goes, oh, I find that all the time. If you've ever been to any Body Worlds exhibits, you can see things. I've seen the craziest stuff. So we're going to keep going here. See, now right now, he's been using this tibialis anterior to pull his fibula over and sort of somehow rotate this. There it goes. And I'm holding that and pushing that fit. See, there's no space between the fibula and the tibia here, so we're just going to get some space. There it goes, right there. And then, you know, there it is, right there. It's coming out. You good, man? There we are. Now, I just felt the tibialis anterior start to drop down. Let's see if we can get it to work like a tibialis anterior. Flex your foot up for me just a little. There it goes. There it goes. We got it. It went. Yes, much nicer. Now, when I push his knee, well, I didn't do it. It just doesn't want to fall in. It'll actually rotate out pretty good. And then when we take it, see, I don't feel that just collapse medial. Now, here's the shortness, this little shortness right here. I'm going to get this. So you see, I've tracked this stuff. I didn't get hung up. That was his symptom. And I feel right here, this tissue is pulling. It's not the suit. It's down almost on the periosteum there. Not really, but right there where the quad does its little split. It's right there. So I'm going to get on it. My elbow. And I'm going to bump it. And I'm just barely above the kneecap, right on the top of there. Dropping down out of there, man. So if you take the time to really cipher things out, I mean, I do use biomechanics a lot, but in this case, I'm not using them so much. But I know underlying what's going on. So I'm not, and sometimes there's just too much to even, you know, reference some kind of biomechanical thing. It's just not there. This just can't be. The body can't have a, there we go. Yes, I like that. I didn't assess his pelvis when we started. Sorry about that, guys. Now we're going to walk you again. I'm not getting hung up on I'm not doing enough either. That's my problem. I end up trying to do way too much because I want to get a lot done. It's not what I need to do. So we're always constantly working to be better practitioners, by, oh, huh. How does that feel?
It's a lot better.
He got some lift out of that. It helped this movement in here some. Keep going. Just walk. Do your thing. And you'll see people do little glitchy things when they walk, and little resets happen. That's what I call them. But you know, now the thing that jumps out to me is this how he works hard up here now that I've taken some of this. Not that this wasn't here before, but now it's not. This stands out more than the legs. Keep going, man. Anything crazy?
I feel like right back.
Yeah. So what went through my head before he said that was, I'm going to do a little sacrum work because we know he's got an issue there. So let's lie you face down. We're getting close, guys. We're going to. It's almost like you laid out on that. So one thing, if I come down here now, what I feel now is there's some tightness here, but a lot of times I won't do anything here. I'll let this play out a little bit and see what happens. I feel some tension in here. We played hockey, that's okay. See where it all plays out. You know, I'd rather somebody come back in and go, man, my toes are really tight, than me whack this stuff and it not need to be whacked or treat. Like what I feel now is I don't feel as much of this crazy lateral rotation. He can, you know, I feel more neutral movement. He goes that way better, but okay, well, let's get going. So we know last time he was way rotated. This edge of his sacrum and ilium were pulled way back. This was pulled way down like this. He was doing that pattern right there. He still got some of that. So when I take him that way, this is still short. It just jams, bumps up. You were feeling that side, right? Yeah. But what he's feeling is this. He's coming around. Here's where he does fake flexion. I say fake flexion or fake extension because that's how he drives that ilium forward right there to make up the difference for it being pulled here. He's here, the ilium and the sacrum. And there's the part he's talking about hurting. I can feel it's real tight. And then he just dives deep right here to get that back to neutral so he can make up the difference. So let's just put him in this pattern, our pattern, and right there's where it's tight. We'll just bump. There's his tuberosity right there. There's the tip of his tailbone. There's the edge of the ilium and sacrum. And right here, that sacroish tuberous ligament, sinus ligament, deep rotators right on the edge. What I can feel is just piled up right there. The obturator probably as well. And I'm going to just put a little love on it. And as soon as I put my elbow on that, I felt was like, no, push it from the other direction. So I'm trying to get it from here going this way. And what I felt his body go, no, push from the other direction. And this is something over time you learn to do. The body will talk to you. You know, one of the things I'm doing, I'm palpating. I'm looking for yes, no, maybe. Now, when I push him into the pattern from this side, I feel like, oh yeah, that. So I'm gonna push him into the pattern. I'll get my elbow in here. No. I'm finding. I'm hunting around for it. There we go. I got to turn. Yeah, there. No. There it is, way down here. So I'm right on the edge of kind of the inferior angle of the sacrum. And what I feel is, as I load that up, I feel is the whole sacrum starts to drop inferior. And as it drops inferior, it's dragging that ilium with it, which is fine. But now I'm holding the ilium right here. I've got this loading into it a little bit. And now what I feel is the ilium, as I hold that sacrum down, the ilium is starting to come up and start to come back around. So I'm nudging it and I'm talking to it, and there it goes. Doesn't mean I'm not working on it. I'm getting in here and getting some of this bed. And there. So I'm right on the posterior, iliac, inferior, whatever that thing's called. And I'm just hanging out on it. I'm loading into him a little bit, but not trying to crush him, because see, that just distorts his structure just enough that I can get it to do what I want to do. That's another thing. If you load somebody up too much, like if you really lean on them, you distort the pattern, and then the body can't figure out what to do. So you got to use enough, and you save your big cannon for when you need to. And it's starting to come with me now. So as I'm right. There's the top of the crest. It comes around here. There it goes. There's that little, this joint right here. So I'm right here, because this is pulled up, like up and back like that. So I'm right there to try to get the sacrum to drop out and the ilium to come back around that way. I think I'm going to use my other arm. Nope. Use that. There we go. So I'm going to take him. Yeah. And this is hard to see because of my, yeah, here we are. You okay, man? Mm-hmm. So I'm tractioning the ilium over and down. There's the tissue that's pulled up right here, this line right here. Right there. There's the top of his ilium. And I'm pulling it over, making a little gap so I can get my elbow in there. And then I'm just going to bump down into there. And I'm creating there we go. I'm creating some space here, man, that he doesn't have. There it goes right there. You all right, brother? Now, I don't always just jump. You know, sometimes I'll do neck work on people first, things like that. I think everybody's got their little preference. I think Jan primarily always does neck work first, and you know that's how he gets his results. And so you have to figure out what works for you, and then branch off of that. But don't be adaptable. Like the whole time you're working, don't get a set idea that by God that's going to change, because sometimes the way things change will shock you. You know, I mean, it'll run the dog around the house, under the house, through the house, out the window, and then all of a sudden, just when you think nothing's going to happen, bam, it lets go. And as I do this, I'm nudging this, and I'm asking it to do something. I'm thinking three-dimensionally. You know, I'm thinking whole sacrum. What's the whole sacrum doing? What are these two pieces doing right here where I'm nudging them? And there they go. And now they're starting to come around. There we go. Good, buddy? Good. Now, there's the sacrum dropping out. And there's that. Okay, now that led me right to the part he was pointing to earlier, right there on the back of that trochanter. So I'm going to come and just bump that while I'm bumping. Immediately it let go. See, I didn't get hung up on the fact that he told me the backs of his trochanters were sore when we started, because in my mind it was like, yeah, that's what, you know, that's a signal of something. There we go. And I want to discover what's going on here. Now sometimes it's like, yeah, that's what I need to work on. But in his case, there we go. And I had a preconceived idea when he came in, like, I'm probably going to do X, Y, Z, and there, yeah. Now, so I like this better. He can go that way. He can go this way. He's getting better. There's a little bit right there. Let's get that. L5, just bump it a little bit. I know we're almost there. There you go, right there. Yes, it's turning. Wow. See, I'm not letting that left ilium go with it. There we go. Well, Thomas got taller. You know, I try not to interject things to clients. You know, I say, what do you feel different? You know, the first, how do you feel?
I don't feel anything.
Yeah. But the thing that jumps out into my mind right away, or that I see, is that like he got a lot longer off of his legs. He got length up off of his legs. All this, and that's, I'm guessing, why this jammed up more. But that's okay. I'm going to do a little neck work here and just tie it all together. And you don't have to, you know, you can do 5 minutes, 2 minutes of neck work on your back for me. Just put it together. We did an extensive amount of neck and head work last time. And when I feel this, I'm just feeling, really what I feel is more that being the issue. This stuff right here, sorry. It's pulling him down and he's doing this. But, you know, I'm not going to get too hung up on that. I could make it a whole another session. But what I feel is this right here is a little Holmes frontal bone. And I kept calling this sagittal suture last time. It's coronal suture. So, you know, I'm not there. Yeah, feel your whole neck getting long. So I'm making sure. See, he, oddly enough, can't do flexion. There he goes. So I'm pulling his head a little bit, but his frontal bone's pushed up. There we go. He doesn't get a lot. There it goes, there it goes, there it goes, there it goes, right there. Yeah, you good? Yeah, I'm just going to move his neck around a little here. So he bends and rotates, bends and rotates, bends and rotates, bends and rotates, bends and rotates. Checking them each one. There's where he's hung, right here in the first rib, second ribs. So reach down with your left arm. I'm just going to get him to side bend it. There it goes, right there. Just went in. Yeah, I'm going to bring him around. Yeah, rest. They're both similar, so reach down with your right arm. When he does that, it side bends his thoracic, so it, there it goes, right there. You know, it went into, yeah, now they're moving. Yeah, there we go. You good? And I always kind of like to check people's sphenoid just to make sure they don't leave out and they're like wonky for days and they can't figure it out while they're having to drink more. But, all right, let's walk you, man. I guess I could do a couple, but yeah, I'm going to quickly just check your sacrum. On your back. No, you're good. You see this all the time, too. You start, they get what? They start doing crazy. I just want to check that. I just want to check it. Little pelvic. Yeah, I feel good pulse here, man. I was not anything super crazy. I'm just going to get there. It comes. Just want to let it know it can integrate into the system. I don't always do pelvic lifts. Sometimes I do, sometimes I don't. Just depends on the client and their system. There we go. Feel that push down. That is pretty hard. Yeah, it is. Yeah. Now walk. So we'll find out what shows up for Thomas. All right, man. What do you feel? Anything bothering you? Anything?
My left side of my rib is loose.
You know, I'm seeing him starting to translate through his pelvis a whole lot better. So we're just going to show that. So if I shift him, yeah, he's getting through here a little better. I can feel it. Does he need some stuff? Probably a little psoas, maybe a little more adductor turnaround for me. But shift. Now let's see if he'll chill. Oh, look at that. See, he's not working as hard. A while ago, he couldn't do that. He had to throw his whole body. See, I can take his pelvis that way now, and his feet are more neutral. So that's much nicer. But anyway, all right. You good? Let's check one thing too. This side's in this way. Yeah, he's starting to get some stuff. Still goes, but it's coming. We're getting there. All right. Any questions? Observations?
People can unmute themselves if they have questions or type it in the chat.
Bill, can you hear me?
Yeah.
Yeah.
Okay. Could you just go back to the very beginning, the primary left-hand side bend,
Mm-hmm.
and the impact on the left femur down into the medial arch?
Right. You want to see that?
Yeah.
So if you just side bending, you can see what happens. Okay, so in a normal side bend, right, this is going to rotate. What happens is it rotates. The compression pushes that hip down on top of the feet. The trochanter shortens here, shortens, drags all this tissue. Come over here.
Oh, sorry.
Pulls it down.
Here's a pen.
It's going this way, this way. It's turning, it's pushing the femur forward. So this tissue's going with it. And then it takes it down into here because to make that happen, as he side bends more and rotates more, this goes over, this shortens down into here like this. This goes this way. All this coming down. Now that's just the outside part, but you got to remember this tissue over here is going to be going this way. Get how it does it. And so other things going to be pulled long, so this is getting pulled up. And then if your compensatory part of that is how he drops down on that femur, which he doesn't do anything like he did. He'll actually rotate now. And you get pieces acting on themselves like these adductors are really pulled up. But part of them will do strange stuff to get around that. But anyway.
Thanks.
It's way more complicated than that, but generally speaking. All right? Any more questions? Me to draw him anymore? Anything need to be drawn?
Any different angles?
Yeah.
So Bill, this is Lisa. When would you get into his forearms to let that go?
Yeah, that's a good question. Probably given what we got done today, I mean, I would probably do this and not so much a lateral line thing, because he's not crazy short here. He looks pretty good. What I see is this, his hockey, and that's also part of this. So getting these forearms would be an alternative to this. Because see, when we look how this much length he actually has up through here. Getting all this gave him a lot of torso length. Turn around for me. And when we got the lower legs today, he got a lot longer here. So when I see stuff like that, I'm like, and you'll see this, you work on somebody's upper body and their lower body will get better. And you work on their lower body and nothing happens. But I would probably third hour, or I might just wait till it shows up. But that's going to help his neck, because see, he's doing this. That's how short he is, and these forearms are tight. There's that one right there. That's how I can So, he's got a lot of tension built up in here, and you can see it up in here too. But, he may come back in next time, and this may look way better. So it's hard to say. I might go, I might want to work on his head again. you know, or maybe here, third hour, you know, get more of his, because he's got a quad thing, you know, he's tied in his trochanter. So you don't have to do it. Like, I remember Jim Asher saying, you don't have to necessarily follow the recipe if you got a reason to do something else. You know, it's just an outline. And, I mean, if he hadn't had, I mean, there could have been argument for doing it the first time, but we did this head stuff because there are always head injuries. Does that answer your question?
It does, Bill. Thanks.
Anything else?
I just wanted to say thanks for doing this. This has been really fun to watch and good videography. And but I wanted to make sure, so this would be this is your second hour process.
It's his second session. It's not necessarily my second hour because I may not do second hour like that on somebody that, you know, he kind of needed it. It was fine. Somebody else, you know, I could have argued for working on his head again, but I may do 2 or 3 same session over and over, a couple, 3 different times, expanding out till something shows up that really needs the next part. Turn around for me. Lisa, also, if you notice, this ties in with this arm stuff too. This shortness in his arms, this chest stuff, the hockey thing. So doing this and this maybe in the third hour, forearms in here, or maybe, you know, that's another option at this point. Now, next time might not be, but you may do this and get a lot of this. You just have to figure it out.
Okay.
Thanks.
Thanks, guys.
Anything else?
Appreciate it.
Yeah, no problem. I know kind of went sideways on your question there, but and you know, like everybody can always benefit from footwork, but sometimes, you know, I tend to get a lot of clients that got a lot of really crazy problems, like multiple broken rib problems and things like that. So I might do 4 or 5 rib sessions in a row on just so I can get something to have some resilience in it, or head injuries, 2 or 3 cranial sessions in a row, or 4. Anyway, anything else? Any other questions? We'll call it good.
Is there a way to watch the first one? I only just found this one. I don't even remember how. So,
you probably found it on Facebook. I posted it. My name is Grayson. You can email me for the first session at graysonvmorrow@gmail.com. If anybody else wants the first session, you can email me and I'll send it to you.
Was that V as in Victor?
Yeah, V as in Victor.
Okay, thanks.
Yeah.
And the first session starts about 15 minutes into it because we just sort of messed up.
Yeah.
So you don't get to see the analysis, but you get to see a lot of head work and things like that.
I'll send my email address in the chat really quick.
Let's take one last look at it while I walk.
Wait, hold on, let me type this. Okay, I just sent it in. Oh, it's sent to Esther privately. Hold on, let me send it to everyone really quick. 1 second.
If you have suggestions for things, send them, because, I mean, I get a lot of really crazy things in my practice. I'm pretty good at just fixing things. So he's starting to even out now. Just let your pelvis relax a little bit. Yeah, there you go. And just rest. You don't have to hold yourself together. There you go. He's trying to figure out how to negotiate this new up through his pelvis out of here. And anyway, we're just walking him just to let him put it all together. He's starting to pick his legs up too, which he did. All right, man. I like that. Remember, it's always a process. I've had clients that have had hundreds and hundreds and hundreds of sessions. There's always something to do. Anything else? All right. Thank you.
Thank you so much.
Thanks.
Bye.
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 Thanks. Bye.